Hello, everyone, and welcome to Therapy Ed's online office hours. Today, we are reviewing voice disorders, and I'm going to take you through this. My name is Dr. Efua Ejapong. All right, so let's talk about our objectives for today. After we are done with this review, you should be able to describe the anatomy and physiology of the vocal mechanism. You should be able to identify the types of voice disorders, and you should be able to identify appropriate evidence-based assessment and intervention for voice disorders. Okay. All right, so let's review anatomy and physiology. I know that when you took your voice class, you went over this, but I always say that you cannot pass your voice questions on the Praxis if you don't have good knowledge of anatomy and physiology. And usually students are wondering, where do I start from? So that's what we're going to go over here. So physiologically, the larynx acts as a sphincter, meaning that it closes off your airway to protect the airway from foreign materials. It's also the system that helps in our ability to breathe, right? So your larynx, your vocal folds have to open or be abducted to help you to be able to breathe. And it is also our sound source. So we're able to produce voice by the vibration of the vocal folds. All right, so with anatomy, what I want you to know is that the larynx is made up of cartilages. There are 3 paired cartilages and 3 unpaired cartilages. We'll be going over that shortly. And then I also want you to know the muscles of the larynx, okay? So there are the intrinsic muscles and the extrinsic muscles. So with regards to the cartilage, like I said, there are 3 unpaired cartilages. These unpaired cartilages are the cricoid, the thyroid, and the epiglottis. So what would help you remember the cricoid is that it is the cartilage that sits directly on top of the trachea. It articulates or moves with the thyroid through the cricothyroid joint. All right, so that cricoid is small in the front and big in the back, and it's big in the back because it makes room for some other cartilages, including the arytenoid cartilage. Okay. The next unpaired cartilage is the thyroid cartilage. This is the largest laryngeal cartilage. And this cartilage, what you probably remember about it from your anatomy class, is the laryngeal prominence, what we call the Adam's apple. All right, so that Adam's apple is more prominent in males than in females because it sits at a 90-degree angle in males, and in females it's about a 120-degree angle. So that's why it's not that prominent in females. But also what you have to know about the thyroid cartilage is that it moves with the cricoid cartilage through the paired processes that allow it to rock forward and backwards. And then the third unpaired cartilage is the epiglottis. The epiglottis, you know about it from dysphagia. You're also going to learn about it, or you've learned about it in voice disorders and probably in your other anatomy classes. But the epiglottis is that leaf-like cartilage that flops over your airway to protect your airway from foreign materials, okay? So your epiglottis is that leaf-like cartilage, and it has a big function of protecting your airway when you swallow. So when you swallow food, your vocal folds close, and then your epiglottis covers your airway so that the food goes through your esophagus and not through your trachea. Okay. So those were the 3 unpaired cartilages, which means they're single. The paired cartilages are the arytenoid, the corniculates, and the cuneiform. The arytenoid cartilage sits in back of the cricoid. Remember that I said the cricoid, which is an unpaired cartilage, is small in the front and big in the back. In the back, you have the arytenoid cartilage that sits there. There are two of them. They have a pyramidal shape, and so they sit on in the back of the cricoid. And this also serves as the posterior attachment of the vocal folds, right? So the arytenoids are very important. Then next you have the corniculate cartilage. And the corniculate cartilage sits on top of the arytenoids. And so what that means is that you have your arytenoids and then your corniculates are on top of it. There are little pointy cartilages, like I said, that sits on top of the arytenoids, and they serve as a landmark in us identifying the aryepiglottic folds. And I will show you that sometime during our presentation here. Then finally, there's the cuneiform cartilage, and this resides within the aryepiglottic folds, okay? So there's the hyoid bone, which is the only bone in the laryngeal system. And this serves as a union between the tongue and the laryngeal structures. And loosely, it articulates with the superior horn of the thyroid cartilage. So when you see cornu, we're just talking about horn. It's the same thing. Superior horn, superior cornu, the same thing. So the superior horn or the superior cornu of the thyroid cartilage articulates with the hyoid bone. All right. So let's go over this again. We talked about the laryngeal system, said that the laryngeal system is made up of 6 cartilages. 3 of these cartilages are not paired, and 3 of these are paired. The unpaired ones are they're the thyroid, the cricoid, and the epiglottis. The thyroid is the largest cartilage, and it's the one that has the Adam's apple or the laryngeal prominence on. The cricoid is the one that has the smaller front and bigger in the back, and it is also the one that sits directly on top of the trachea. And also in its back, it houses the arytenoids. And then there is the epiglottis, and this is the leaf-like structure or the leaf-like cartilage that covers your airway when you swallow. All right, so those are the unpaired ones. The paired ones are the arytenoids, the corniculates, and the cuneiform. So the arytenoids, we said, are 2 pyramidal cartilages in the back of the cricoid, and they serve as the posterior attachment of the vocal folds. And on top of the corniculates, on top of the arytenoids sits the corniculates, and then there's the cuneiform, which is embedded in the aryepiglottic fold. Please go over this information because this information is very important when we talk about pathology, okay? All right, so another part of anatomy that I want you to know has to do with the vocal folds and the structure of the vocal folds themselves. So the vocal folds are made up of layers, and there are 5 of these layers. The topmost layer is the epithelium. So think topmost epithelium cover. That's the epithelium. The next layer is the superficial layer of the lamina propria. So that is inwardly, that's the second layer. The third layer is the intermediate layer of the lamina propria. The fourth layer is the deep layer of the lamina propria. And the fifth layer is the thyrovocalis muscle. So of all these, I want you to remember them, but I want you also to remember that the superficial layer of the lamina propria is also called Ranke space. All right. So the superficial layer of the lamina propria is also called Ranke space. Remembering that is very important because we're going to talk about Ranke's edema, and I want you to be able to remember what that is. So Ranke's, this is how Ranke is spelled. All right. So also know the glottis. The glottis is just the space between the vocal folds. That's all that is. And it is the most important laryngeal space for speech. The reason why the glottis is important, or is the most important laryngeal space for speech, is that when you close the vocal folds, you're able to build what we call subglottic pressure. And so opening the vocal folds or air passing through the vocal folds sets the vocal folds in vibration. But also the subglottic pressure is used for other things that are not necessarily speech related, okay? So just know that the space between the vocal folds is the glottis. When the glottis widens or when it opens, we call it abduction, abduction. And then when the you put your vocal folds together, we call that adduction. All right. And air passes through the vocal folds and cause the vocal folds to vibrate. And I talked about the subglottic area, which is the area below the vocal folds. You're going to hear me talk about subglottic pressure. So just know that subglottic just means the area below the vocal folds. All right. So also know what we mean by ventricular folds. And the ventricular folds are just what we call the false vocal folds. And you can see them right here. So these are the ventricular folds. These are the true vocal folds. The ventricular folds are also called the false vocal folds. Very important to know because we're going to talk about ventricular phonation, and that is simply where a person vibrates or sets the false vocal folds in vibration instead of the true vocal folds or along with the true vocal folds. All right, so now let's talk about muscles, all still on anatomy. So the muscles of the larynx that you should know, I've said you should know the intrinsic muscles and the extrinsic muscles. The intrinsic muscles are muscles that have their origin and insertion all within the larynx. And the extrinsic muscles have one insertion within the larynx and one elsewhere. So the intrinsic muscles, their main function is to adduct, abduct, tense, and relax the vocal folds. So again, their function is to close, which is adduct, open, which is abduct, tense the vocal folds, and relax the vocal folds. So the first intrinsic muscle that I want to introduce you to is the thyroarytenoid muscle, or the TA muscle. And this muscle refers to the deepest layer of the vocal fold structure. So when I gave you the vocal fold structure, the epithelium, superficial layer, intermediate layer, deep layer, the last layer is the TA muscle, the thyroarytenoid muscle. And it has two sections, the thyrovocalis and the thyromuscularis. Vocalis is the medial section and it tenses the vocal folds when it contracts, and the thyromuscularis is the more lateral section and relaxes the vocal folds when it contracts. The next muscle of the larynx is the PCA, the posterior cricoarytenoid muscle. And this functions to abduct the vocal folds. It's the only abductor of the vocal folds, the abductor muscle. And so make sure that you remember this for any of your Praxis questions, the PCA. Then there's the LCA, the lateral cricoarytenoid muscle. And this muscle, when it contracts, it adducts the vocal folds by moving the muscular process posterior laterally and the vocal process medially. So with these muscles that we're talking about, I am a visual learner, and so I would go back and look at where the muscles are located, and that usually really helps me remember them. But however you choose to learn this, just make sure that you know the muscle, you can identify it, and you know its function. Remember that I told you the PCA is the only abductor muscle, so that should help you, right? So that you know that the PCA is the abductor, the rest are doing other things like adducting, tensing, and relaxing. All right, there is the cricothyroid muscle, the CT muscle, which also has two sections, the pars recta and pars oblique, and their function is to tense the vocal folds. And that would end it for the intrinsic muscles. Now let's talk about the extrinsic muscles. And usually I don't spend a lot of time on the extrinsic muscles, reason being that a lot of times you've covered that in your dysphagia course. So I will just mention those and then we'll move forward, okay? So the extrinsic muscles, their general function is to, one, elevates the larynx within the vocal tract, and two, to depress the larynx. So elevating the larynx is just the action of the suprahyoid extrinsic muscles, and then the infrahyoid extrinsic muscles, they depress the larynx. Depressing means lowering, and obviously elevating means raising. All right. And so I have the suprahyoid muscles, and these include the digastric, mylohyoid, stylohyoid, and geniohyoid muscles. And their main function is to elevate the hyoid bone and the larynx. Then there are the infrahyoid muscles, and these muscles include the sternohyoid, the sternothyroid, omohyoid, and the thyrohyoid, and their main function is to depress or lower the hyoid and the larynx. All right, I think this is the last piece of anatomy, and then we'll talk a little bit about physiology and move on to talk about pathologies. So nerve innervation is very, very important. I want you to go back and review that information, but know the general information being that the vagus nerve is the nerve that is responsible for innervating the larynx. Okay, so the vagus nerve is responsible for innervating the larynx, but I also want you to know that the recurrent laryngeal nerves and the superior laryngeal nerves. Know that the left recurrent laryngeal nerve has a unique path. And because of this path, a person could go in for a heart surgery and then come back with a voice problem. So the left recurrent laryngeal nerve, as you can see in the picture, it courses under the aorta. And so what that means is that any surgery in the vicinity of the heart, the aorta area, there's a likelihood that the vagus nerve could be impacted. And so after the surgery, regardless of the outcome of the surgery, the individual could have voice problems after surgery because the vagus nerve was impacted. That's very important also. I think I've seen a question somewhere about that, right? That was asking about the path or the course of the left recurrent laryngeal nerve. And so that you have to understand that the vagus nerve is responsible for innervating the larynx, and the left recurrent laryngeal nerve, because of its path, could also impact a person's voice. All right, so let's talk a little bit about physiology. So how do we change pitch? Changing pitch requires two mechanisms: lengthening the vocal folds. When a person lengthens their vocal folds or stretches the vocal folds, that reduces the mass of the vocal folds, and so the vocal folds are able to vibrate faster, and that will result in a higher pitch. Let me say that again. Lengthening the vocal folds reduces the mass of the vocal folds and causes the vocal folds to be able to vibrate faster, and that results in a higher pitch. And then there is fundamental frequency can be increased by increases in subglottal pressure. Again, subglottal pressure, we've met it here, right? So subglottal pressure is the pressure below the glottis. And we're saying that when you increase that pressure, you are able to have a higher pitch as well. Okay, so now let's talk about vocal registers. So there are three registers that relate to speaking. And when we talk about register, we're just talking about pitch, right? We're talking about fundamental frequency. So there is what we call the pulse register, and that is the register at the low end of the fundamental frequency scale. So the really low end, right? This is pulse register or glottal fry, right? So this is pulse or glottal fry. Then there's the modal register, which is just a person's normal fundamental frequency range, which usually a person would usually use. So what you're hearing me have is my modal register. Then there's the falsetto or the loft, and that's what frequency range. All right, so that is falsetto or loft. Just know these registers as well, terminology and also what they are. Then also know mechanisms for changing loudness. So how do we change loudness? Changing loudness requires a doubling of lung pressure, and that can increase the sound source output by about 9.5 dB. Okay. All right, so now let's talk about types of phonation and vocal fold closure. This information is actually in your therapy ed book. If you don't have a copy, I will encourage you to get a copy because it summarizes all the information really nicely in a way that you're able to, recall it and understand it for taking the Praxis. So types of phonation and vocal fold closure, I will just highlights a couple. The first is breathy, right? So breathy is when a person has a lot of air. So when people are leaking air, pretty much, or there's a burst of air that accompanies the vibration of the vocal folds, that sound, that pitch, that is when you say someone is breathy. Usually strained sounds like a pushed vocal quality, and physiologically, that has to do with irregular burst of air through vibrating vocal folds with full vocal fold opening and closing with increased medial pressure. So right? So there's a lot of you can hear the person pushing. There are a few others on there that, like I said, you can take a look at and read for yourself, or just review if you've talked about it in your voice class. All right, so that leads me into talking about vocal pathologies. Vocal pathologies can be categorized into three. There are structural, functional, and neurologically based pathologies. We're going to touch on all of these main categories, and I'll give you examples of those. The pathologies we're going to talk about here are not exhaustive in any way. There are more that you can go back and read. So structural pathologies, I've seen vocal nodules on the Praxis quite a bit, right? So vocal nodules, you have to know, these are benign pathologies, usually caused from phonotraumatic behaviors. So phonotraumatic behavior is just any behavior that impacts a person's vocal quality, such as yelling, speaking too loudly, or singing or speaking beyond a person's range. And typically nodules form bilaterally, and they result in an individual having a raspy voice, a hoarse voice, breathy, and a voice that easily fatigues. If the person is a singer, then they're going to have loss of vocal range and loss of endurance. And usually, voice therapy will take care of it. Also, we would teach our clients vocal hygiene. That refers to how to take care of the vocal mechanism. But I wanted to point out here in this picture, you're seeing the nodules that are formed bilaterally right here. Okay. All right, so the other structural pathology has to do with polyps. And polyps are fluid-filled lesions that develop in the superficial layer of the lamina propria. Remember that we met superficial layer of the lamina propria when we talked about the structure of the vocal folds. And this superficial layer of the lamina propria we also call Ranke space. Um, Vocal fold polyps tend to have their own blood supply, and they may result in hoarseness, breathiness, roughness, global sensation. That's a sensation that there's something in the throat, and effortful phonation. The person, phonating because of the polyp, they might have, be leaking air. And so their phonation tends to be effortful. And this can be treated or managed using behavioral voice therapy, talking about vocal hygiene, but also phonosurgery could be one way of treating this. So phonosurgery is just surgical treatment where they would go in and cut or remove the polyp. Okay. So next is generalized edema or Ranke's edema. Remember that I said to remember Ranke's. So Ranke's is, again, the superficial layer of the lamina propria. So we're just saying that swelling could actually happen there. And usually that tends to be as a result of chronic exposure to cigarette smoke or laryngopharyngeal reflex. So acid reflux that goes past the esophagus into the larynx. That is what we call laryngopharyngeal reflex. And look here, you can see these really swollen vocal folds, all right? And so symptoms for those include a lowered pitch, varying degrees of hoarseness, increased vocal mass. As you can see, sometimes the person could have sleep apnea, and they may also have swelling that's large enough that it causes symptoms of dyspnea. And apnea and dyspnea just have to do with breathing, right? So apnea just means a person is not able to breathe, and dyspnea just means they have difficulty breathing. So they have breathing problems. So how do we take care of Ranke's edema? It's removal of the irritant. So if the person is a cigarette smoker, they removing that, vocal hygiene, and phonosurgery. I wanted to highlight that. Notice that all the structural pathologies we're talking about have to do with the structure of the vocal folds, right? So you can see that the structure has been impacted. There's some swelling somewhere, there's a mass, or there's a growth. That is what we mean by structural pathologies. Laryngitis is also another structural pathology, and laryngitis could be bacterial or it could be viral, and it could also be caused by traumatic conditions or autoimmune diseases. And depending on the cause, the management will differ. So if it is a bacterial infection, then antibiotics can take care of it. If it's a viral infection, you let the virus run its course. But in all of that, maintaining vocal hygiene is very important. And then there are granulomas, and granulomas usually grow over contact ulcers. So when a person has contact ulcers, usually in the back, so on the arytenoid processes, granulomas tend to grow over those contact ulcers. And usually they could be bilateral or unilateral. And voice symptoms include hoarseness, breathiness, difficulty increasing vocal loudness, prolonged warm-up time, and voice therapy. So there are so many different types of treatments, but vocal hygiene treatments is important. The next is Candida, and Candida is a yeast infection that can be present in different parts of the body, and it can also be present in the laryngeal area. And usually it results in a person having a pressed vocal quality, breathy, pain may be present sometimes. And from treatment of this medication is used to take care of the yeast infection and the removal of any predisposing factors. All right, so then there is laryngeal papillomas, and I want to point that out here. You're looking at these raspberry-like growths on there, and these are the papillomas. So this is an inflammatory condition, usually as a result of a person having the HPV virus. Then there's presbylaryngus, and presbylaryngus is, I'm sorry. So presbylaryngus happens as a result of sarcopenia, and sarcopenia just means a wasting away or thinning of muscle tissue, which happens as a person gets older. So as a person gets older, their muscles waste away and thin, and that could impact their voice. And so you're looking at these vocal folds here, which are bowed because of sarcopenia. And so voice symptoms include reduced loudness. The individual might sound breathy, and males, their pitch tends to become higher with age, whereas females tend to have a lower pitch with age. Voice therapy can help, but there are also other types of treatments, such as use of injectables. So they would inject different substances into the vocal folds to bulk the vocal folds up, to take care of the thinning, and then medialization procedures as well. Laryngomalacia, this is the most common cause of inspiratory stridor in infancy. So some children are born with immature, I call it immature larynx. So the larynx, the cartilages are soft and floppy. And so when the person or when the baby breathes in, the larynx collapses and then it comes back up when the baby breathes out. And so you're going to hear, it's not consistent. Usually it's an occasional stridor that the infant would have, or intermittent stridor. And it starts just a few days or weeks following birth. And the degree of stridor increases as the depth and rate of breathing is increased, usually for treatments as children get older or with maturation. The cartilages harden and they're fine. But there are also other treatments or sometimes where surgery might be needed. All right, so still under structural pathologies, let's talk about vascular lesions. And when you hear vascular, you think of blood vessel, right? So the vascular lesion that I wanted to talk about is varix and ectasia, and this originates in the superficial layer of the lamina propria, and maybe as a result of, phonotraumatic behavior such as shouting or singing, and it may lead to a loss of vocal range in singers and hoarseness, and some individuals might complain that in their higher frequencies they're not able to get as high as they want. Managements include vocal rest until any blood is reabsorbed, and vocal hygiene is important. And if surgery is needed, cold instrument dissection is ideal. Another vascular lesion is vocal fold hemorrhage, and hemorrhage is just direct damage to tissues as a result of exposure to blood. When the superficial layer of the lamina propria is affected, it can have devastating effects, including the person having dysphonia, which is just difficulty with the voice or problems phonating, so problems producing voice, complete aphonia, which is where they're not able to produce voice at all. And for management, phonosurgery, and in the acute phases, complete and total vocal rest in order to allow the tissues to heal. All right, so those that we talked about are all structural. Like I said, that's not an exhaustive list, but I did go through quite a few of those structural pathologies. Just go through your notes, any structural pathology that I didn't talk about. It's worth reviewing. Make sure that you review that, know the symptoms, know the treatments, just so that you're able to better explain or answer a question on the praxis. Then there are functional voice disorders, and these disorders are disorders where you're not necessarily going to see anything, structurally wrong, but the vocal folds are not working the way they should. So puberphonia is one, and that is where an adolescent male has a seemingly maladjusted growth of the larynx, and so they might maintain a high-pitched voice, and symptoms usually include, in addition to the high-pitched voice, them sounding breathy and having really low vocal loudness. Treatment of that tends to be, speech pathologists would work with them. So that'll be behavioral management. And we would do things like, giving them biofeedback, using computerized software, some relaxation techniques to help reduce muscle tension. Then there's ventricular phonation. Do you remember us talking about ventricular folds? So the ventricular folds are the false vocal folds, right? So ventricular phonation just has to do with vibrating with the false vocal folds, or the false vocal folds along with the true vocal folds. And so individuals who do that might do that because maybe they have some muscle tension, and we're going to talk about muscle tension shortly. But this might happen and tends to result in a low-pitched voice, reduction in vocal range, reduction in loudness, and hoarseness, and global sensation, and sometimes pain in the ear. If the vocal folds are unable to produce voice, then voice therapy, pharmacological treatments, depending on what the cause of the problem is. All right, muscle tension dysphonia. So I have met a few students who confuse muscle tension dysphonia with another type of disorder that we're going to talk about, which is spasmodic dysphonia. But I want you to know that muscle tension, as the name suggests, has to do with an increased tension in the muscles of the head and neck, right? So it's just a tension, and I shouldn't say just, but it's tension in the head and neck, and that is usually what causes this voice problem: strained vocal quality, high pitch. The folds really sometimes are not able to close completely. And usually when a person is stressed or has anxiety or depression, that could result in a person having MTD. How is it treated? Voice therapy usually works very well. Some therapeutic strategies include biofeedback, laryngeal relaxation techniques, resonant voice therapy, accent method. These all tend to be helpful for MTD. All right, so now let's talk about the last category, which is neurologically based pathologies. And the first neurologically based pathology is unilateral true vocal fold paralysis. And this is where one vocal fold is paralyzed and the other works, right? So when a person has gone for some surgery, the recurrent laryngeal nerve has been cut or something has happened to it, and so it's not able to innervate one vocal fold, but then the other works, that would be a unilateral true vocal fold paralysis. And the symptoms that you see really vary. So you might have symptoms such as aphonia, where the person really cannot have a voice at all, or they might have completely normal voicing, depending on where the vocal fold was when it got paralyzed. So if it was close to midline, then the other vocal fold that works can move midline and then meet it or be close to meeting it at midline. And so it can, the individual can produce normal voice or have mild dysphonia. But if the vocal folds were paralyzed when the folds were completely abducted or in abducted position, then this individual is going to sound breathy, weak, and they might have dysphagia as well. So with paralyzed vocal folds, usually they would use the wait and see approach to see if the nerve renovates itself. So there's a 6-month window time where there is they would wait to see. Behavioral voice therapy to facilitate vocal fold closure, so some pushing techniques, vocal function exercises, and so on. And then there's a surgical approach, which consists of medialization or vocal fold augmentation to get the paralyzed vocal fold to midline so that the working vocal fold can meet it. Then there is bilateral true vocal fold paralysis. And this is where both vocal folds are paralyzed. And you're probably wondering, if both vocal folds are paralyzed, how can the individual talk, right? Or how can they phonate? Well, if the vocal folds are paralyzed, and they're not paralyzed at a point where they were completely abducted, then the individual can still have a voice, right? If they were closely approximated before that happened, they can have a voice. If the vocal folds were completely closed, abducted when the paralysis happened, then the immediate concern is the person's ability to breathe, right? So they might do tracheotomy or cordectomy, and cordectomy is just widening the glottis, right? So taking one of the cords out or part of the cords to be able to widen the glottis so the individual is able to breathe. Is there anything I'm forgetting on this one? I think that's all that I wanted to talk about on bilateral vocal fold paralysis. Then there's spasmodic dysphonia. Spasmodic dysphonia is the one that I said usually students confuse with muscle tension. Muscle tension is muscle tension. It's a functional disorder. And spasmodic dysphonia is believed to be neurologically based. So we don't know the origin of it, but it's thought to be related to basal ganglia dysfunction. And there are two main types of it. There's the adductor spasmodic dysphonia, and there's abductor spasmodic dysphonia, but a person could also have mixed. So I probably could say three types, but there's abductor and adductor, or a person could have mixed. Spasmodic dysphonia, so as you can tell from the name, spasming, it's a spasming of the vocal folds, right? So adductor spasmodic dysphonia just means that the vocal folds spasm on adduction, and abductor spasmodic dysphonia is just a spasming of the vocal folds on abduction. All right, so that leads us into assessment. But before I go over assessment, I want to really encourage you to go over the pathologies, understand them, understand which ones lend themselves well to vocal therapy treatments versus which ones have to be treated pharmacologically or surgically. I want you to understand what is happening in the different pathologies, because that's very important for you to know as a speech pathologist, and also to be able to pass or answer the Praxis questions, okay? All right, so with assessments, like with any of the disorders that you have talked about, case history review is very, very important. Do that case history, self-assessments, oral peripheral examination. You know how to do all of that, so I will not go in depth into those. There are a few things that I'll highlight specific to voice. Assessment of respiration, Auditory perceptual assessments. These are assessments where the clinician is listening to an individual's voice and rating the voice, rating vocal quality of the voice. And then subjective assessments based on clinical impressions of the SLP. And then instrumental assessments, and that include video stroboscopy, acoustic assessments, and aerodynamic assessments. With assessments, I found this also in the therapy ed book, and I thought it was a good, nice summary of the different types of assessment that you will do for voice evaluation. So they talk about laryngeal imaging, where you pass a scope down, either through the nose or the mouth, so that you're able to look at the vocal folds. So with laryngeal imaging, it could be a rigid stroboscopy that is done, and the rigid stroboscopy is just where they would put the strobe, go through the mouth and look at the back of the throat. Then there is the flexible endoscopy, and this is the same as the piece equipment that goes down through the nose and to look at the vocal folds. The difference between the equipment that you'd use for fees and voice is that the voice one has the strobe lights, and that is the lights that actually helps you to see the vocal folds in slow motion. Then they talk about auditory perceptual measures, and a few of the measures they mention are Cape V, which is a scale that you would use, was actually developed here in America by SIG 3, Asha SIG, and it rates your vowel production or your voice production, a person's voice production in 3 contexts: vowel, and then sentences and conversation. So it's a rating scale where the SLP listens to the vocal quality and rates the individual's voice. I would encourage you to look for the KV and see how it looks. You might be giving a case with results of the KV, and you should be able to understand and interpret that. Then there's the Graba scale, which is a more national scale, and it's a very common measure for rating a person's vocal quality. Acoustic measures. So you want to know what fundamental frequency is, and fundamental frequency is just the a person's pitch. Perceptually, we call fundamental frequency pitch. Then there's intensity, and intensity is what we perceive as loudness. And there, you're also interested in the maximum phonation time, which is the maximum amount of time when a person can hold or sustain a vowel. Okay. There's jitter, and jitter has to do with perturbations in pitch or variations in pitch. And shimmer is variations in loudness or variations in intensity. All right, so these measures, I want you to look at them, there are deeper explanations to them also in the therapy ed book and in a few of the books that I'm going to show you at the end of this session. So these acoustic measures I also deliberately put here because you have to know what fundamental frequency is. And I said that perceptually, it's correlates as pitch. Intensity, perceptually, it's correlates as loudness. Maximum phonation time is just the longest time that a person can hold a vowel with a deep inhalation. So you ask your patient to take a deep breath and go, ah, and you record how long they're able to do that. Jitter information is the cycle by cycle change in frequency or variations in pitch, you can put it that way, or pitch perturbations. I used a few different terminology there. Then there's shimmer, which is the cycles to cycle change in amplitude or amplitude or less dependent on average intensity, but we're talking about the variation in amplitude. Then there's harmonic to noise ratio, and this quantifies the amount of any periodicity in the vocal signal. Okay. And there's the Grabas scale, the KV, stroboscopic and visual examinations. All of these are tables that are in the therapy ed book that I copied and put in here. Okay. All right, so now let's talk about treatment. So treatment can be direct or indirect. So indirect treatment is where the clinician is encouraging good vocal health and wellness. So reducing phonotraumatic behaviors, and I said phonotraumatic behaviors are any behaviors that impact the vocal health. So unnecessary coughing or throat clearing, excessive loudness, so yelling, screaming, any of those behaviors are called phonotraumatic behaviors. Indirect therapy would also focus on conservative use of loudness. I've talked about that. Attention to any potential laryngopharyngeal reflex. So I mentioned laryngopharyngeal reflex when I was talking about polyps and nodules, I believe. And this is where you have acid reflux, right, coming up from the stomach to the esophagus, and it going past the esophagus into the larynx. And because the tissue in the larynx is mucosal membrane, the acid can really impact the laryngeal area and cause a lot of irritation there. And so if you have acid reflux, taking care of that, sometimes using medication or lifestyle changes would help in taking care of the voice. Adequate hydration, drinking a lot of water. We always say drink half your weight in water daily. So that's very important. And holistic elements such as good nutrition, enough rest, regular exercise, and good mental health. Those are all indirect therapy. They're counseling that the speech pathologist or the voice pathologist would give the clients. Then there are voice direct therapy approaches, and there are so many of these. A few of them are on here, but when you go to the ASHA portal, you're going to see so many of them described in depth, and I highly encourage you to do that. So vocal function exercises have been shown to benefit in improving vocal range, stability, flexibility, and resonance in normal and disordered populations. There is resonance voice therapy, which focuses on optimizing vocal quality, conversational training therapy, phonation resistance training exercises, and there are so many different techniques. Like I said, go to the ASHA portal, you just type in voice disorders, and you're going to have a lot of information. And these exercises are described in depth for you as a clinician and also as a student. So studying this to pass your praxis, and also you're able to use it in your clinical practice. All right, so that would bring me to the end of the review. Do you have any questions? If you think of any questions, let us know. I'll be more than happy to respond to your questions, okay? Well, it's been a pleasure teaching you today, and I wish you the very best on your praxis. I hope you pass it and pass it very, very well. Okay, bye-bye.